Good morning, everybody. I am Dr. Ashish Nabar, cardiac EP from Mumbai, and I work as a coordinator for this IHRS DNB Arrhythmia teaching program, which once again and every time I proudly declare that it's the fourth year of this program, and we have been managing to run it without fail every month, first Sunday, 10 o'clock. And that's purely because the IHRS faculty has always been obliging, no excuses, and they have always contributed willingly to the program. The only freedom that they have is they can really choose the topic of their choice. And thankfully, it happens to be both ablation and devices alternately. So I think the attending postgraduates for whom this program is meant get a fair idea of what's on in the EP world. This is primarily designed to help them to prepare for their exit exams. We do understand that 12 programs a year doesn't intend to complete a syllabus or anything, but at least some of the departments who might really not be having a full-time EP might just get a gist of how EP goes on and arithmology goes on, and it can stimulate their reading and not leave it for the last minutes of pre-exam or something like that. So it's really looked upon as a clinically useful part of the curriculum, which also would help their exams. So the only request I make to the faculty is that this program is tailored purely in the interest of the DNB postgraduates, and that's what we keep in mind. I have been also lucky in terms of the moderators who are, in my view, the best in that subject or on that topic, and therefore today we have three moderators who I feel are likely to do or bring out the most important aspects from the presentations. And on this occasion, I requested Professor Narayan Nambudri from Sri Chitra Institute at Thiruvananthapuram, a leading electrophysiology department of this country. And when you go through the presentations, you'll realize how vibrant that department is in electrophysiology. And it's always looking to do new things, publishing, and a lot of clinical work, of course. So I won't waste much time, stand between you and the academics. I would hand over to Dr. Nambudri. I request him to explain to our postgraduates what was the concept behind selecting these three research papers for discussion and introduce his faculty. So let's roll. Narayan, you're mute. You're on mute. Narayan, you're on mute.
Okay. Yeah. Sorry for that. Thanks, Dr. Ashish. It's in fact my pleasure and privilege to take the leadership role in moderating this session. And I'm fortunate to have three pioneers in the field of electrophysiology as co-chairs or the moderators along with me. When Dr. Ashish suggested that we should have certain topics like journal club presentations, which we were lacking in the IHRS DNB session in the past. I also felt it is a good idea. Of course, journals, it's a bridge between research and academics. And most of the original concepts come as journals, research work in major articles in major journals. And so we have decided to select three important topics in the field of advanced treatment in the field of cardiac electrophysiology. The first is on pacing along with the subcutaneous ICD, and the second one on a novel concept whether low dose anticoagulation would be helpful in certain scenarios, a Tricia trial published in NEGM, and the third one on SBRT, that is the radiotherapy treatment for ventricular tachycardia refractory cases. And we have three cardiologists, young electrophysiologists with a good number of publications. Taken together, I'm sure they have publications in circulation, they have European Heart Journal and Heart Rhythm, all three of them taken together. And they're only just 2-3 years post-DM, still they have performed very well in the field of academics. So without wasting much time, may I request Dr. Saxena, the senior most electrophysiologist in the group, to say a few comments and invite Dr. Sudipta.
Yeah, hi. Good morning, everybody. It's indeed a pleasure to be here in this group. And the topics, I was very fascinated by the selection of topics because these are at the cutting edge of what we consider medical research. And we have to see how they find clinical application. And the first topic, I think we should start the program. So I would like to invite Dr. Sudipta to present the first topic.
Oh. Uh, Good morning, respected teachers, my colleagues and friends and juniors. I want to especially thank my guide and my teacher, Dr. Narayana Namudri sir, for giving this opportunity to me to present in this platform of IHRS. And without wasting time, I'll directly go into the topic. So today, my topic of discussion, as we know, that we are presenting 3 journals, journal articles, and the first article is modular ATP trial. So this was published just few months back in the NEGM. The journal was published around 1 month back, a modular communicative leadless pacing defibrillator system. So this study was predominantly based in the countries of Europe and few countries from USA, and more than 30 countries were involved in this work. So coming to the background of the study, so what is it? What is it actually? So this is basically subcutaneous ICD system with leadless pacing system. So that I'll delve deep into it. Why subcutaneous ICD require another pacing system in the form of leadless pacemaker, that I'll discuss in subsequent slides. So before going into the combination of leadless pacing and subcutaneous ICD system for shock therapy, we should know the complications of transvenous devices. As we know, the current standard of practice is especially in India, is most of the time is transvenous ICD devices for defibrillation therapy. But as we know, the subcutaneous ICD also goes hand in hand in managing those kind of patients in Western countries. So what are the problems of transvenous devices, ICDs? So here the list of complication of transvenous devices, that we can see that during insertion, the most important risk factors are pneumothorax, hemothorax due to pleural puncture, and cardiac perforation during device lead screwing. And the chronic risks involved in the transvenous devices are lead-related problems like lead infection causing infective endocarditis, or lead displacement and dislodgements. And in further in the chronic phase of these devices, the venous system might get thrombosis, and venous system might get occluded. All those situations can lead to problem if there is any upgradation. We are planning for upgradation or any other devices through upper limb venous system. And another problem of lead related problem in transvenous ICD are lead fracture and lead failure. Lead failure mainly related to insulation breach, and that may lead to abnormal rise in impedance, abnormal fall in impedance, or rise in capture threshold, and sensing failure. That may lead to capture failure and inappropriate device function. So, and also during removal, there are also risk of when we plan to remove any transvenous ICD devices, there are multiple risk factors. As most of the time we are scared to remove those transvenous lead system if the lead is very old. So that can have risk of cardiac perforation while removing, and also pneumothorax and hemothorax, all those risks are involved in these patients. And many cases of deaths are also reported in case of transvenous lead removal. So all these are the complications of transvenous devices. So the paradigm shift from these transvenous devices to subcutaneous ICD has already started since the last decade. So, and those two, subcutaneous ICD and transvenous ICD, go hand in hand while managing the cases of, while planning the cases for ICD. So this is the very beautiful demonstration of how these two fare in terms of risks and benefits. So advantages of subcutaneous ICDs are that it eliminates the needs of any vascular access. So as we know, the pulse generator is kept in the subcutaneous plane on the left side, left axillary region, infraaxillary region, and the lead is being placed on the left parasternal area, just below the skin in the subcutaneous plane. So there is no involvement of the intracardiac structure. So there is no risk of any vascular access related problem. There is no, and as we are not dealing with the intracardiac structures, so there is no there is a possibility that we might not require any fluoroscopy while positioning the subcutaneous ICD and lead system. And there is also, as we know, the lead related complications are more in transvenous ICD system. So subcutaneous ICD system lead malfunctions are very less compared to transvenous ICD. And also, as we are not going into the venous system and not puncturing, so there is nil risk of pneumothorax or cardiac tamponade. And as we know that transvenous ICD system, the lead identifies the EGM, local electrogram, to differentiate between the native rhythm versus the VT. But so EGM, it is difficult to differentiate between SVT and VT. But as we know, the surface ECG is more, we can differentiate more clearly versus one rhythm of SVT versus VT. So as we are placing the electrode outside the heart, and the rhythm differentiation will be much better in case of subcutaneous ICD compared to transvenous ICD. And there is a relative ease of extraction for subcutaneous ICD, as we know that it is outside and there is no involvement of transvenous lead, and there is no risk of cardiac perforation and tamponade and pneumothorax. So all these are advantageous for subcutaneous ICD, but and also we know that all these are problematics for transvenous ICD. But transvenous ICD has its own advantages, like this has pacemaker function. The most important advantage of transvenous ICD, that it can pace whenever required. That means it can help in bradypacing, and it can help when the VT comes. If we can give anti-tachycardia pacing, and VT can be terminated without any shock, without any apprehension, without any pain to the patient. So that is the most important advantage over subcutaneous ICD in case of transvenous ICD. And as you know, this small, generally the transvenous ICD will have small pulse generator, better battery longevity, and if we require to deliver CRT therapy, that pulse can also be upgraded. And for transvenous ICD is also available. But despite having all the advantages of subcutaneous ICDs, why you are not putting for all patients, and why it is not overtaking the transvenous ICD? Because of the disadvantages of subcutaneous ICD. So what are the most important disadvantages of subcutaneous ICD? That it cannot pace whenever required. So that means there is no anti-bradycardia pacing. Maximum it can, after the shock is being delivered, it can pace transcutaneously, it can pace for up to 30 seconds. Beyond that, subcutaneous ICD cannot pace. So that means any requirement for pacing, bradypacing for a patient is an absolute contraindication for subcutaneous ICD. Now, and what are the other disadvantages of subcutaneous ICD? So in case of VT reentry circuit related ventricular tachycardia, the ATP can successfully terminate in most of the cases of ventricular tachycardia. So as there is no pacing lead in subcutaneous ICD, there won't be any anti-tachycardia pacing. So so these are the two most important disadvantages of subcutaneous ICD, for which we generally tend to plan for transvenous ICD. And not to give the importance that the cost of subcutaneous ICD is also higher, especially in our country, it should be kept in mind. So how this data came? Previously, Praetorian investigators have already proven that there is composite device-related complication and inappropriate shock were almost similar in both subcutaneous and transvenous ICD, citing the fact that both subcutaneous ICD and transvenous ICD are almost equal in terms of safety and efficacy profile. Also, another study, the Atlas study also has shown that the complication rate of subcutaneous ICD and transvenous ICD, device-related complications are almost similar in both the situation. But as we know that sub-analysis has shown that lead complications are more in case of transvenous ICD, and that is compensated by non-related complications of subcutaneous ICD, leading to equalization of risks in both subcutaneous ICD and transvenous ICD, making both of them equally efficacious and equally safe for management of this kind of patients. So with this, coming to the background of this study, that as we know, subcutaneous ICD cannot give pacing, it cannot give pacing backup and cannot give anti-tachycardia pacing therapy. So the thought of this study was, if we connect wirelessly one subcutaneous ICD device to wireless leadless pacemaker, and we can have a communication between those two, we can give brady pacing as well as anti-tachycardia pacing to terminate the VT. This was the main concept behind this study. And already I have mentioned that Praetorian and Atlas study and many other short-term studies have already proven that lead-related complications were less in subcutaneous ICD, and both are equally efficacious. And due to its extrathoracic position for subcutaneous ICD, there was no brady and anti-ATP pacing, which can be improved with this leadless pacing system. And as we know, as I have told, that need of ATP is a contraindication for subcutaneous ICD. So where should we think of these indications? So subcutaneous ICD usually class 1 indication for pediatric and Gooch patients with no venous access. So transvenous pacing, transvenous is out. So acquired stenosis and obstruction of central veins, or previous any risk of future infection or any prior history of infection will lead to to plan for subcutaneous ICD in place of transvenous ICD. So these are the usual indications for planning for subcutaneous ICD. So this was the system used in this study. So subcutaneous ICD device, which will be kept infra axillary location, and a leadless pacing lead will be put on the RV apex. And this is tined leads, not screwing lead, and this is called Emperor leadless pacemaker system. And the ICD device was Emblem S ICD, and this was sponsored by Boston Scientific. So what are the patients included in this criteria? The usual indication for ICD, all the patients of class 1, class 2, and class 2B indication, according to all the consensus guidelines, were taken into consideration. And moreover, few other patients were taken which those patients had higher risk of monomorphic VT or any higher risk of recurrent monomorphic VT. So any LV ejection fraction with history of sustained VT or VF for secondary prevention, it was taken with significant scar, and any syncopal episode deemed to be arrhythmic origin was also taken. And two other groups were taken with LV ejection fraction of less than 50% if there was sustained VT for secondary prevention, and even if there was non-sustained VT with LVEF of less than 50%, they were also taken. And ischemic cardiomyopathy patient with LV ejection fraction, low severe LV dysfunction patients were taken. And non-ischemic cardiomyopathy with significant scar were also taken. So what is significant scar in this study? Significant scar meant any scar involving more than one segment of the 18 segment model MRI or echo model. So more than one segment involvement of the scar was considered as significant scar, and any significant scar with LV ejection fraction less than 50% were taken for this study. So overall, the risk of this of having monomorphic VT on follow-up was higher in the whole cohort of this group. So what exclusion criteria? The usual exclusion criteria were taken into consideration, like previous complication of infection and any transvenous lead remnants within the heart from previously implanted CIED were a contraindication for this device. But to remember that transvenous lead remnants outside the heart, for example, if the lead is in the SVC, were allowed, because this will not hamper with the placement of the leadless pacing lead. And any ACS syndrome which are within the 40 days as per standard guidelines were excluded. So this was the study of prospective non-randomized single arm global study involving more than 30 countries, more than 30 centers in different countries, and it used to assess the performance and effectiveness of this novel system of MCRM system and MPOWER leadless pacing system. The study was done from July 2021 to January 2024 for around 2.5 years, and 293 patients were included. And because of the variability of 6-month follow-up appointment, 162 patients were taken for interim analysis for safety endpoints. So these are the okay, 7 minutes left. Okay, fine. So this is the profile of the recruitment. So ultimately 282 had implantation or attempted implantation, out of which 162 had 6-month endpoint analysis. So it was taken. So out of this 162, 2 died, and 160 patients of the trial had 1-month system testing, and on follow-up 2 more died, and ultimately 153 were continuing to be followed up. And out of this total, 8 patients died. 3 died due to cardiac pump failure, 2 died due to non-cardiac causes, and remaining 3 causes were not well known. And none of them died of any lead-related or device-related complications. So this is the baseline characteristic of the patient. So average age was 60 plus minus 12 years, and most of the patients were male of 83%. And importantly, the primary prevention percentage was 53%. As compared to other studies, the secondary prevention patients were higher in this study. And most of them were ischemic cardiomyopathy, around 61%, and non-ischemic cardiomyopathy were 34%. Coming to the ventricular arrhythmia, almost ventricular tachycardia was detected in 53%, and all forms of sustained, non-sustained, monomorphic, polymorphic, all forms of tachycardia were there in this study group. And out of this 162 patient, there was no transvenous pacemaker in those patients. Only 9.9%, 10% of the patients had transvenous defibrillator prior to it, and it was supposed to be removed during the procedure, and subcutaneous defibrillator were present in almost 42% of the patient. So only if the subcutaneous defibrillator compatible with this leadless pacemaker was available, then only leadless pacemaker was implanted at the time of implantation. So coming to the results, as we can see, the 100% patients successfully implanted. That means 162 out of 162 had successful implantation during the first implantation procedure, and out of those 74% had successful implantation on the first go. That means there was no repositioning was required. Out the 27% required repositioning, out of which one repositioning was required in 14%, and the other 13% required more than one repositioning. And as you can see, the procedure time was significantly less. When there was no repositioning required, the procedure time was defined for leadless pacing system for sheath in to sheath out, and for subcutaneous ICD implantation from first incision to the last suture. So when there was no repositioning, the procedure time was 28 minutes for leadless pacemaker. The blue lines indicate that only when we are positioning the leadless pacemaker, and if both are combined, that is the red part. So if there is no repositioning required, leadless pacemaker required only 28 minutes mean time, and if both are required, the time was required 70 minutes. And with one repositioning and more than one repositioning, the time interval was not much higher, but slightly higher. So, and fluoroscopy type we can also see that no repositions, only 6 minutes for leadless pacemaker and 6 minutes for subcutaneous ICD system. And it is not significantly higher when the we required a repositioning. So coming to the safety endpoint, it analyzed the safety endpoint data. So the performance goal was 86% patient without any complication. So major leadless pacemaker related complication free rate was 97.5%. That means 97.5% patients without any complication from leadless pacemakers point of view. So only 4 patients had major complications in terms of 2 myocardial perforation due to leadless pacemaker system with cardiac tamponade, which was managed medically, and one patient had vasovagal syncope during procedure, and which was managed medically, and one leadless pacemaker was implanted into the left ventricle, probably because of misguidance of the sheath into the left side via interatrial communication. That is probably a small AST or PFO. And retrievals were done for 2 post-implantation patients. One for the same patient which the lead was implanted on the left side, and for one patient who developed heart block subsequently, and for which he had to undergo dual chamber pacemaker. And mortality, in terms of mortality, 4 deaths in the first 6 months, 2.5%, and none of the deaths were attributed to the device or procedure related complications. Now coming to the leadless pacing performance, as you can see, the less than 2.0 volt was taken as cutoff for performance goal with 80% performance goal, and it achieved significantly, and 97.4% had pacing threshold of less than 2 at 6 months visit, and only 4 patients had more than 2 volt pacing threshold at 6 months visit, that is 2.1, 2.5, 2.5, and 2.6 volt. And the pacing threshold was fairly constant and low for all patients, around 0.7 and 0.6 at 6 months follow-up. And ROV amplitude sensing was also good, like 11 and 14 millivolt at implantation and 6 months visit. And pacing impedance was around 700, 800 ohm. So now comes the question of wireless communication. So ICD has to communicate with the leadless pacing system, and this is the system which has unidirectional communication. That means ICD will communicate with the leadless pacing system, not the vice versa. So, so wireless communication, the performance goal was 88%, which was achieved. 98.8% had communication success. That means there is no communication failure in between the subcutaneous ICD and the leadless pacing system. And it was tested in all 4 positions, right lateral, left lateral, standing, and sleeping position. And it achieved 98.8% success. And we can see the least we can achieve is at least in 2 positions, the communication was perfect and there was no communication failure. And coming to the other important part, which is anti-tachycardia pacing therapy, and we can see that appropriate the total episodes were 31 episodes in 13 patients, and appropriate therapy was given in 93% patient, and appropriate shock was given in 6.2% patient. And ATP success rate was 61%. As compared to transverse lead system, it is almost similar. And ATP accelerated arrhythmia in 3 episodes, and all ATP which failed to terminate the tachycardia were terminated by appropriate shock therapy. So there was no failure of the whole system in terms of terminating the tachycardia. And no patients reported any pain or discomfort during ATP or communication. And no patients requested leadless pacing therapy inactivation for any reason. So, and there was no failure of therapy due to device communication failure. And the one important aspect of this leadless pacing plus ICD, subcutaneous ICD system is inappropriate therapy. The inappropriate therapy was seen in 14 patients with 36 episodes. This was little higher compared to normal transvenous system, probably because of this lead related the overcounting of the T wave and VPCs.
So sorry to interrupt. 2 minutes more.
Yes, I'll just finish. So overall, the ATP therapy was perfect for this pacing system. And complication, as I have already mentioned, total 18 complications were there. And tamponade was 2, which managed medically. And leadless pacing, the serious complications were very less in terms of this device problem. And coming to the freedom from major procedure-related complication was very less. And as I have already mentioned, the performance goals were achieved with communication success in all positions, and pacing thresholds were uniform and low in almost all patients except 4 patients. And coming to the limitation of the study, so this was non-randomized trial with no comparator group, hence reported only on performance and not on efficacy. And study enrolled patients with high risk of ventricular tachycardia who were intentionally selected. So it may not be generalizable in all populations of primary and secondary prevention patients. So conclusion of the my study is leadless pacemaker in wireless communication with the subcutaneous ICD exceeded performance goals for freedom from major leadless pacemaker related complications with good implantation and free of complication rates. Thank you.
Thank you, Dr. Sudipta. Well presented. Can we hear the comments from Dr. Aurasarthaya?
Good morning, everyone. Thank you very much for the invitation to be here. Very nice presentation, Dr. Sudipta. I think, a couple of points just to summarize, mostly covered by you in every way, is that this is an observational study. First and foremost, this is an observational study that Boston Scientific designed, mainly also to get FDA approval for their leadless pacemaker, the Empower system. But they have done it in a way that there's, it's testing the modular CRM between the SICD, which has been there for several years, and their leadless pacemaker, which is the third on the market following the Medtronic Micra and the Avier system. So it is a continuous registry, out of which, with the cutoff time that they used in January, they had already enrolled 290 patients in this, but only those with 6 months of follow-up already available have been included in this study for publication. And it has performed pretty well. I mean, the first safety endpoint is for the leadless pacemaker, and it's comparable to the historical cohort or data from the MICRA and the AVIR. And then the second efficacy endpoint is also related to the leadless pacemaker, which is the pacing capture threshold. And you look at it, mostly it's below the 1 volt at 0.5 milliseconds, a 0.4 millisecond pulse width, although their performance goal was set at less than 2 volts. But the most interesting thing is the communication testing, which has been excellent. And one point I would like to point out, I would like to emphasize to the audience is this: how does this communication occur? So this communication, when they say wireless, it's not Bluetooth, it's unidirectional conductive communication. So what they did is it's actually impulses sent from the shock coil, which is on the sternum, to the can, and they've repurposed lead integrity kind of algorithm that they had. So when the device detects that there is an arrhythmia and it wants ATP to be delivered, what it does is it sends these communication signals from the shocking coil to the can, and this is intercepted by the leadless pacemaker. So technically, the communication vector should be parallel to the leadless pacemaker placement. In practical purpose, most of us, put leadless pacemakers on the septum, so it comes right in the communication vector. And it has performed pretty well, 98.8%. It is picking up these signals. And this is only unidirectional. And then the leadless pacemaker then verifies if what it's seeing, the true electrogram, is what the device has told it. So say the device is overcounting T waves, and it finds that the true ventricular rate is less than the conditional zone of 150 or so, it will not deliver ATP. But it cannot communicate back to the device saying that you have counted wrong. So that's the one interesting feature, and I think it's performed well, and I'm sure there's going to be more publications coming from this registry. I think I'll stop here with the comment in the interest of time.
Okay, so that means it's going to extend the spectrum of subcutaneous ICD with the addition of this modular ATP option. Any comments from the chat box or Dr. Saxena, Dr. Nabar, Deepak?
Yeah, a couple of questions. Does it give a atrial synchronous ventricular pacing as well for body, or just a VVI pacing?
No, this is exactly akin to a VVIR micro pacemaker. So it's passive fixation, time technology. There's no atrial sensing feature. So this is like the first generation micro. So this whole modular system at best still is a single chamber ICD. So you would not consider it for anybody who requires atrial pacing, AV synchrony, or BiV pacing. So that's how, I think this will get approved pretty soon in the US, and I'm sure it'll be available globally. But again, it's a very expensive system for a single chamber ICD. So in specific situations, young patients who don't want, for primary prevention, but don't want a lot of hardware, recently I did one where people having VF, they don't really require ATP also. But anyway, so that would be the sort of patient population to use this for.
I think it's an important development, and although it overcomes the one limitation of subcutaneous ICD, otherwise the subcutaneous ICD is as good in terms of safety and efficacy as the transvenous ICD. And this was one problem that it overcomes, but cost has been a major barrier as far as adoption in India is concerned, because subcutaneous ICD as such is about 4 times expensive as compared to transvenous ICD. And this will further add to the cost. I think it will be equally expensive, double the cost of SICD system probably, if I'm not wrong.
Or else in the early days of ICD, in addition to DFT testing, a pre-discharge VT induction was done to see how it terminates. So is there such a protocol one time or multiple times?
So it's a great question. With subcutaneous ICD, when it started being implanted, we always did, there were always DFT testing done. So I remember even in training, doing these DFT tests. But right around that time, about 4 or 5 years back, there have been publications where they do a 10-joule shock. And so it's a low energy shock. And if your shocking impedance is less than 90 ohms, it correlates very well with a successful DFT.
So I'm
even in
asking, I'm asking not only about DFT, but also VT induction to see if the monomorphic VTs are treated correctly.
in
Do
the
they do a
implant
EP
procedure,
study,
I don't.
non-invasive EP study? Do they do that pre-discharge to see?
With this system,
Yeah.
specifically, I don't know that they had that in the protocol. Obviously, this trial has closed, and I spoke to one of the investigators who was in this trial, but I don't think they're doing that, and I didn't see that anywhere in the algorithm. I think, yeah, I mean, they just looked at it from a efficacy standpoint with close follow-up. I see your point to make sure that it is working for that particular patient.
Sure. Narayan, should
not.
we move on?
Yeah, I think we are 5 minutes late.
Yeah.
So thanks, Dr. Russ.
Thank you.
Great to have you here.
Thank you
We'll move
for
on to the
having me.
second, we'll move on to the second presentation of today's session. It's by Dr. Sai Kiran Kakarla. It's on an important topic that is actually anticoagulation, an article published in NEGM, that is stroke prevention in subclinical atresia trial, a widely quoted one. Dr. Sai, you may start, and Dr. Saxena, anything to add, or you want to make comments at the end?
No, I think we can start. I would like to mention that this is a very, very important topic because it is now a very standard practice to give anticoagulation to atrial fibrillation patients to reduce the incidence of stroke. And this practice so far has not been applied to patients where we have device-detected subclinical atrial fibrillation, because we have not been sure about two things about the incidence of stroke in this population. And second is, we don't know what level of or what burden of subclinical AF would be clinically important as far as the stroke is concerned. And secondly, we were not aware whether anticoagulation will bring down the incidence of stroke in this population sufficient enough to counterbalance the possibility of bleeding. So the safety versus efficacy has not been established in this population. And recently we have had two studies published, very important trials published. One of them is Arrhythmia that we are going to discuss today. So I think it's a very, very important, and all of us should be very deeply interested in this. So I would request Dr. Sai Kiran to please proceed with this, with the presentation.
Yeah, thank you, sir. At the outset, I will thank my mentor, Dr. Nambudiri sir, and the IHRS members for giving this opportunity. So I'll be giving a brief outline regarding clinical and subclinical AF, and then I will review the Arrhythmia trial and analyze the findings, and we'll see the treatment review, and we'll conclude the session. Before going to the study proper, I'll just brief out the various definition involved in the atrial fibrillation. As you know, the atrial fibrillation is nothing but an ECG finding, not only an ECG finding with irregular RR interval with no P waves or fibrillatory waves, which has to be documented on a 12-lead ECG or rhythm strip. So, but the distinction is often blurred between clinical and subclinical AF, as with the advent of multiple devices like Apple Watches or many electronic devices, the distinction between clinical and subclinical AF is blurred. Though it is blurred, the people often use clinical AF widely in multiple papers because the clinical AF include the spectrum of the patients who had the symptoms related to the atrial fibrillation, maybe because of rapid rate or maybe because of heart failure related symptoms. Whereas the subclinical AF patients are absolutely asymptomatic and they don't have symptoms except for the rhythm abnormality, which they found maybe incidental or maybe during device interrogation. Traditionally, usually all device detected AF patients are traditionally called as atrial high rate events. As you see here, the atrial high rate, this is you can see a typical dual chamber pacemaker where you can see the multiple atrial electrograms in the atrial EGM, whereas ventricular is with normal V-sense or V-phase electrogram. This is a typical electrogram of AHRE or atrial high rate event detected on a device interrogation. So whenever clinician encounter this sort of finding, they call it as atrial high rate event. So traditionally, there are multiple papers describing multiple cutoffs for the atrial high rate events. Usual accepted one is around more than 160 or more than 175 beats per minute, and it should be at least 5 minutes to rule out the artifact related issues. So once you see the atrial high rate events, then you have to review the ECG, whether the patient had clinical atrial fibrillation with the ECG, at least 30 seconds in the strip or any Holter. If it is there, then it is called as a clinical AF along with clinical symptoms. If the patient has, if the patient doesn't have these part of symptoms, then or ECG finding, then it is termed as a umbrella term under subclinical AF. So what is peculiarity about subclinical AF is, as you know, the atrial fibrillation has a clear evidence to treat the patients with anticoagulation. Failing that, patient will have stroke. Whereas the subclinical AF, it is just AF that is less than 24 hours. In short, we can say the atrial fibrillation which occurs less than 24 hours, which probably most commonly detected under devices. So whatever previous accumulated data shows that it increases the risk of stroke with 2.5 times when compared to the normal person. So when you compare the subclinical AF between less than 6 hours and more than 6 hours, the person who has got more than 6 hours had twice the risk of stroke when compared to the less than 6 hours group. So when you, what happens with this subclinical AF, will it progress to the clinical AF? So studies showed that almost 1 in 5 or 6 patients will progress to frank or clinical AF within 2.5 years of detection of this subclinical AF or IHRS. So with this background, we just briefly see what is the risk of the stroke in untreated patients in both subclinical AF and clinical AF. As you know, well aware of this AVROS trial, where the clinical AF, they have divided into different subgroups like paroxysmal, persistent, and permanent AF, and they looked into the risk of stroke. As you see, as the AF increases the duration from paroxysmal to permanent, the risk of stroke almost increases. It increases. Whereas the case with subclinical AF, which was clearly demonstrated in ASSERT trial, where when you have the subclinical AF less than 24 hours, you can see it is almost much lesser when compared to the paroxysmal AF. So, and the risk almost equal to the paroxysmal or persistent AF when the subclinical AF duration is more than 24 hours. So from this landmark trial, the area of the subclinical AF is dichotomized into two subgroups, that is more than 24 hours, less than 24 hours. So the people who had atrial fibrillation detected in their devices more than 24 hours are being treated like a clinical atrial fibrillation based on their IHRS score. It is in the guidelines also. Whereas the data from the less than 24 hours is still unclear. So this was proven in multiple RCTs also, as you can see in meta-analysis also, where you can see the longer duration of AF will clearly have a risk of stroke. So is there any evidence for the atrial fibrillation depending on the duration and the IHRS score and the risk of stroke? This is a important study, which is a retrospective and prospective study, which was done over the 25,000 device implanted patients, where they have looked into the treatment and atrial fibrillation patterns. So they found that patients with higher IHRS scores and longer atrial fibrillation has the higher risk of stroke events, as you can see in this corner. Whereas the patients with the lower IHRS score and less frequent duration of atrial fibrillation has minimal events as comparable to the normal population. So they also seen whether the treatment, some patients of those groups are being treated with anticoagulation, and they have analyzed the patterns also, and they have found this results, like where the patients who had intermediate group, as we saw in the last slide, this area, when we treat with anticoagulation, their risk of getting stroke is almost close to the normal population. So with this observational study, there is a lot of scope for the research in this area. So that paved, as you see, this is a pictorial representation of what I showed in the last two slides. So you can see when we plot IHRS score and IHRS or subclinical AF, whatever the burden on two different axes, we'll get like 9 possible areas to compare. Distinctly, patients who have low risk they can be observed for the development of future atrial fibrillation closely. And whereas patients with a higher risk, higher charge flask and longer duration of more than 24 hours from the ASCENT trial, we are very sure that these patients should be treated. So there comes the border zone area where there is a high risk but low scarf burden, or high risk with like high burden of AF with intermediate risk. These subset of the patients are still in the gray zone. Whether to treat with anticoagulation or not is the question. So that gives the scope of the two RCTs with the Arrhythmia and NOAF AFF6 trial. So currently we are discussing this Arrhythmia trial. So it's a multicentric RCT, which was nodal center was in Canada, McMaster University, with multiple centers in North America and European centers. So the study design is pretty simple, where they have taken the patients of around, they identified the patients of around 4,000 patients who had an implanted pacemaker or device or any implantable cardiac monitor, which whom had experienced subclinical AF episodes for at least 6 minutes to 24 hours, with multiple further risk factors. I'll elaborate in the inclusion criteria. And they divided into two, like one treatment trial with apixaban. They have given either 5 mg BD or 2.5 mg BD, depending on their requirement according to creatinine clearance, obesity, and advanced stage related issues. And the other arm received aspirin of standard dose of 81 milligram per day. So it was a double-blinded and double-dummy treatment. So the patient investigational group will receive 2 drugs. Active control group also will receive 2 drugs. So one of the both drugs will be a placebo and other drug will be a test drug. So that reduces the bias also. And they estimated the outcome by defining the primary outcomes and secondary outcomes. So these are the inclusion and exclusion criteria which they have used. All the patients who had implanted device with at least more than 1 episode of subclinical AF, and it should be less than 24 hours. And the age should be more than 55 years with risk factors of stroke like hypertension, heart failure, diabetes, any vascular disease, and female gender. And they excluded the patients, those who had documented AFib even after inclusion also. Say, for example, one patient in this one of both treatment group and control group developed AFib after inclusion, then they excluded that patient. So any current or within last 6 months indication of anticoagulation also they excluded. Needless to say, extreme low GFRs and drug allergy patients, pregnants, and other drug interact, the patients who receive other drugs which interact with the ecosprin and apixaban, they were excluded. So they devised outcomes into 2, the efficacy outcomes and safety outcomes. Efficacy primary outcome, they included only stroke, which they had included TIA with imaging evidence also, and also systemic or peripheral vascular embolism. And regarding safety outcome, they defined the major bleeding. They chose the major bleeding as a safety outcome. And regarding secondary outcomes, they included individual ischemic and MI data, and also total cardiac and non-cardiac deaths, and composite of all primary outcomes. So sample size was pretty standard. They have taken from the ASCENT data, and the statistical analysis was pretty standard. So I'll go to the baseline characteristics of the patients. As you can see in both apixaban and finally they have allotted almost 2015 patients in apixaban, whereas in aspirin group almost 1997 patients, with a total group of 4,000 odd patients. The mean age is almost similar in both groups to 75 plus years. And the mean CHART score is 3.9, with patients who are CHART more than or equal to 4 is 60% in both groups. And when we see the ethnicity, South Asian people contribute only less than 1% in this study. As you well aware that even ethnicity also plays a major role in the incidence of atrial fibrillation and the age of atrial fibrillation onset. So when you see they included more of European and American onset of the American ancestral patients. Continuing the device baseline characteristics, the device which they have included predominantly as a pacemaker patients, almost close to 70% in both groups. And the number of episodes of subclinical AF were included, almost 60% of the patients in both groups were in between 1 to 5 subclinical AF events. Interestingly, they have seen that the patients who had no subclinical AF episodes prior to the randomization for the 6 months, they have seen it is almost in 17% of the both groups. They don't have any episodes of subclinical AF in last 6 months of prior to the randomization. And they have almost 2 close to 55% of the patients had longest episodes between 1 hour to a bit less than 6 hours of the event, documented in both groups. So before going into the outcomes, we must definitely know that both arms of the patients have a significant dropout rate, with a discontinuation rate of around 24% in apixaban group and 23% in aspirin group. And as I told previously, the patient who developed atrial fibrillation, clinical AF, they were discontinued from both arms, and they have treated like a clinical AF with a proper anticoagulation as per the guidelines. So those constitutes almost 34% of the patients in both groups. And 22% of the patients died in both arms, in apixaban and aspirin groups in both arms. The median follow-up duration is 3.5 years. So when we look into the outcomes, initially for the efficacy outcome, as you can see with the stroke or systemic embolism as a together all events, as you can see in apixaban groups, the incidence of stroke is less than 1%, that is 0.7, whereas in ecosprin group, it is 1.2%, which is statistically significant. And we further dissect out the nature of stroke into ischemic or embolic stroke of unknown etiology. Still it holds relatively okay with apixaban, that is less than 1%, whereas in ecosprin it is 1.02%. Interestingly, this study group also analyzed the severity of the stroke in both arms, which was not seen in the patients which was not seen in the previous trials. As you can see, they devised like with the help of their modified ranking score, where they have divided into apixaban and ecosprin group, like where they have divided the low risk and high risk, like low severity and high severity stroke events, where you can see there is with a ranking score of more than 3. The severe stroke events are less often seen in the apixaban group, whereas the disabling stroke events are seen in aspirin group. This is a like new finding in this study. Among the secondary outcomes, the deaths from the cardiovascular and non-cardiovascular are not very similar, not very dissimilar in both between those two groups, and it is not statistically different also. So they have mainly emphasized the fact of reduction of this primary outcome in the patients with apixaban group, and they like emphasize that there is a 37% of the reduction in stroke events with apixaban group when compared to the aspirin alone. So when we look into the safety outcomes, where you can see obviously with the apixaban group, there have been high events recorded, like almost to the tune of 1.7% for the patient year, whereas in the aspirin group it is still 0.9%, which is clinically and statistically significant. And they have further subdivided the types of presentation in the major bleeding, where it is fatal bleeding is almost same in the both groups, and they didn't find any significant difference between the two groups, like apixaban and ecosprin, in severe disabling neurological hemorrhagic strokes. So, and this study has concluded, like among the patients with subclinical atrial fibrillation, apixaban lowered the risk of stroke or systemic embolism with a than ecosprin, but with a higher risk of major bleeding. So there are some limitations and things we need to consider while taking the results of this study. Since there is a high rate of discontinuation to the tune of almost 25 to 26% in both arms, as well as they have analyzed both in intention to treat and treatment analysis, which showed a significant reduction in stroke and systemic embolism, but the dropout rate is pretty high. And lastly, the trial results data is more applicable to the implantable devices. We still don't know how these results translate into the patients with wearable monitors or other eye devices, etc. So, like my key takeaways for this study, like in 4.4, like first key takeaway is, like for clinical AF, as per the previous data, like in Avaro's trial, apixaban clearly performed well when compared to the ecosprin. In this study, there actually 2/3 of the patients were on ecosprin. We all know that ecosprin also increases the risk of bleeding. So this trial essentially compared the apixaban group with the placebo for efficacy, whereas it used an active comparator for the safety. So, but in practice, when we are treating the patient, we will be treating whether we will use apixaban versus nothing. So in such scenario, the efficacy will be remain same, like whatever reduction it is achieving with the apixaban, but the actual bleeding risk will, when compared to the apixaban versus ecosprin, apixaban versus nothing will be almost like higher. So that means in a true clinical translation, the bleeding risk may be much higher. And my second takeaway like point from this study is like, so in the patients with clinical AF, when you see the chart score, it is almost 5% of the patients had risk of stroke. So there is no wrong in treatment in the patients with clinical AF with anticoagulation. In the last previous trial, which we have seen, the Averroes trial, the subclinical AF, when the chart score is like 2, the reported incidence is 3.7. Whereas in this patients, in this trial, the reported incidence of aspirin group is 1.2, which is further less. So that means the stroke risk for the subclinical AF is substantially lower than compared to the usual clinical AF with an identical chart score. So on the third takeaway point from this study is like, so interestingly, they have performed the severity of the stroke event between the ecosprin and apixaban group. They have significantly found that the patients who are an ecosprin group have a severe disabling stroke when compared to the aspirin. So we may have to take in consideration while discussing the patients in the borderline group of the patients when we discussed when we shared the clinical decision in initiating versus discontinuing the anticoagulation as well. And coming to the number needed to treat, as the study boasts like 37% reduction in the stroke, but the relative risk is that 37%. When we translate into absolute risk value, the risk reduction is very marginal. That is just 1.6% over 3.5 years. So when we translate into the number needed to treat, it comes to whooping amount of around 62 persons. So to get a benefit for 1%, this is quite high. So there comes the again tie-in. Is there any subset where the risk-benefit ratio is almost favorable among this subclinical AF? So if we analyze the substudies which affect the chart score versus duration of these IHRE, they may provide some valuable insights with this in this particular subset. So which subset should be treated with anticoagulation, which subset should not be treated. So the same RTCA group has presented recently in IHRS 2024 in Boston their data with in relation with the chart score. This is the baseline chart score division in their subset. As you can see, as we told already, if you include the more than 4 or more than 4, almost 60% of the patients are included. But majority of the patients are 4 and less than 4 group of the patients. And if you see the stroke risk in 4 or less than 4 subsets, it is almost minimal, with or without, even if you treat or if don't treat, those patients doesn't have much significant risk of stroke. But it is in quite contrasting, like stroke, those patients who had chart score more than 4, like that is 5 and above, if you treat them with anticoagulation with apixaban, the risk reduction is very dramatic, and it is almost 2.2% over the 3.5 years. And it is clinically significant. And when we see the bleeding profiles also, it is not much significantly different with ecosprin. So this slide we have seen initial in the starting slides, where we have shown that the duration of AF and the longer duration and the higher charts have the higher risk. So when we offer the treatment also, they fare better. Like similarly in this data also, the reduction of aspirin, the reduction of the stroke is higher with the initiation of ecosprin group, like rather than keeping the patients on ecosprin. Or if we clinically translate, even if you keep the patient without anticoagulation, those patients who have high chart score with subclinical AF, the patients will have higher stroke rate of more than 2.2 when compared to the apixaban alone. So they in this subgroup analysis, they have clearly found that those patients with a chart score of more than 4, this is a specific subset which fare better with the anticoagulation when compared to the other groups. And interestingly, among the sub-analysis, they found that almost 18% of the patient doesn't have subclinical AF, as I mentioned initially in the patient baseline data. And among this patient also, those patients who never had documented who had documented very infrequent episodes of IHRE, their absolute risk of stroke is much lesser, that is less than 0.5% per year. So, and coming to the other part, that is the frequency and the duration of IHRE versus stroke risk. So this sub-analysis from the RTCA data presented in the recent IHRA Berlin conference, they have not published yet. The frequency of the duration of longest IHRE and higher number of the duration within 24 hours subset doesn't matter. Like the duration doesn't matter when we count the IHRE within 6 hours, 6 minutes to 24 hours. It does matter only if it crosses more than 24 hours. That means, so however long or however short is the duration, it didn't show statistically significant difference in getting the stroke. So with the inclusion of all sub-analysis and main data of RTCA trial, so people are like hypothesizing like those patients who has clinical AF, they should be anticoagulated without doubt. Those patients who has AF more than subclinical AF more than 24 hours, they should be anticoagulated as per guidelines. This is from the ASSET data, which was well validated. And less than 6 minutes, patients should be monitored serially as the patient has a higher bleeding risk. When we saw this part of data in the like chart score and comparison to the like a duration also. So when these particularly subsets patients who have 6 minutes to 24 hours with higher chart score, here particularly 5 more than 5 or equal to 5, those patients needs anticoagulation. So so needless to say that this is just part of an iceberg. Like just we are contemplating the data from the intracardiac monitors or implantable devices. But this data doesn't, we don't know how it translates clinically into the patients who commonly come to at least our day-to-day practice, like young patients coming with Apple iWatch rhythm disturbances or whatever their home monitored devices showing rhythm disturbances. We don't know about how to treat these sort of subclinical, these part of subclinical AF. So is it an end like, like in an published data from RTCA group, so those patients who had a previous stroke, though the patient had, despite the chart score less than 4, the reported stroke incidences was 3.1%, which is pretty high when compared to the other, more than like in that data, more than charts 4 also. So like still it is unclear like whether the patient, whether we need to take importance to the prior stroke history or AF burden alone into the, even when we consider for the anticoagulation, particularly in this subclinical AF patients with less than 4 chart score. So many unknown structural electrophysiological aspects may also play a role in it. Like a recently well-known concept of atrial cardiopathy, where this concept of atrial cardiopathy, instead of looking the atrial fibrillation into dichotomous variable of present or not present or less than 24 or more than 24, they look in a different perspective. Like an atrial fibrillation is a kind of a continuum of a disease, whether it starts with a muscle electrostructural alterations initially, then myofibrillar loss, then followed by myocardial density loss, then followed by amyloid deposition. Between somewhere here, atrial fibrillation starts appearing. Initially, it starts with very infrequent duration of atrial high rate events. As the disease progresses, it potentially like establishes its full-blown effects of the atrial fibrillation. So we don't know still like the patient whether mechanical part of dysfunction or electrical subtissue level part of the atrial ultrastructural changes, whether they translate clinically into the stroke or not. Still, it is an area of debate and area of active research. So I can conclude like these are the like whatever knowledge gaps are present in the atrial cardiopathy field or where in subclinical AF field. So just we are targeting the RTCA trial partly explains the one of the knowledge gap in this broad spectrum of atrial cardiopathy rather than atrial fibrillation. So I can say like this is not still an end. It is we have not reached the beginning of end also even. Thank you.
Thank you for that wonderful presentation. You have dissected all the aspects, bringing out all the relevant points, the confusions, and also looking into the recent presentations in major international journals. I also agree. We also do agree that it is not even the beginning of the end. We have 3 areas major. One is the chart score. Another is atrial substrate, which is represented by atrial cardiomyopathy at pathophysiological level. Probably could be measured with a LAVI or some other parameters, electrical scarring. Then you have recorded atrial fibrillation. With the advent of all these long-term monitoring in devices and all, and the chances of having recorded an IHRE is very high. So many patients will be labeled as IHRE, and this is an important area. I look forward to Dr. Saxena sir's insightful comments on this.
Okay, thank you. Wonderful presentation. I think he covered every aspect of the trial and the background knowledge as well. I completely agree with Dr. Putri. The CAT-best score is not complete. I mean, there are so many other factors which lead to increased incidence of stroke. Like, yeah, please mute everybody. So there are other factors like even renal failure or atrial myopathy or presence of sac in the echocardiography. There are so many other parameters also which indicate higher propensity for stroke, and they are not part of the trial as a part of the CAT-best score. As far as trial is concerned, I think he covered every aspect very well. I was very curious to know why they chose aspirin as a comparator because it, other than mitigating the chances of bleeding or difference in the bleeding rates, it doesn't serve any purpose. We all of us know that aspirin is a class 3 harm indication as far as stroke prevention is concerned. We never use aspirin, so that's very relevant point. The sub-analysis has been published last week about which indicated that patients who have CHAS-BAS score 4 or more, they benefit, the risk benefit ratio is favorable, and less than 4, it is definitely against it. So I think it's a very important development, and we are picking threads as far as evidence collection is concerned in non-clinical atrial fibrillation, because so far we know that the clinical AF model for stroke prevention is very well established, but that cannot be translated to subclinical AF as of now. But probably this gives a very good insight into that maybe we need a higher threshold in CHAS-BAS when the subclinical AF is concerned. The other trial was negative, NOAA AFNet trial, but I think probably because of the fact that the inclusion criteria was they required only one additional factor, a thrombotic risk factor for inclusion of the patient, while this included a higher CHAS-BAS score, only 4 or more, 3 or more. So that was one difference which possibly led to a difference in efficacy. So I think it's a very important trial, and as rightly pointed out, the wearable devices have created a huge set of people who are having subclinical AF or suspected to have subclinical AF. So that increases the burden on the healthcare systems to, first of all, to establish the clinical diagnosis. So we have to do long-term recordings in those patients and to see whether they are actually having atrial fibrillation, particularly the watch-directed AF and all that. They are not very reliable sometimes. So that has increased the burden, and that has also put us in a fix as to whether to anticoagulate these patients or not. So we are definitely in the need of more criteria, more definite criteria to decide which patients require anticoagulation. I think I'll stop here. It's a very important topic, and maybe Ashish, you can give your final comments.
Anil, a quick question to you and Narayanan. I'll play the reverse card. Because these devices have a long-term continuous monitoring for AF, will we ever think about if you have 2 years of no AF or whatever the duration that we will stop anticoagulation? Will we use them in that direction?
Yeah, we are moving that direction because the watches as of now, like for example, Apple Watch, it just records true ECG only when we want it, 30-second strip, and that's a true ECG. We put a finger on the knob and it creates the lead one, and we can record ECG. Now they are creating a ring or something to be worn on the other side, which will then have a continuous recording of lead one, and that will change everything completely. Once you have continuous real ECG recording happening, that will, I'm sure, detect a lot of patients. But this, search and treat strategy has failed in many other diseases. I mean, it happened in coronary disease. There was a time when people underwent, everybody was made to do TMT and then positive TMT, angiography, asymptomatic, OM disease, treated with the stenting. And now we have taken a reversal. It happened in prostate cancer, it happened in breast cancer, it's happened like routine mammography is now being discontinued in many countries. So it is this search and treat strategy, whether it works or not is not yet certain. And there are so many reversals that we are, I think, in the middle of nowhere at the moment. It's uncharted territory.
Yeah, when you have a patient with a high chart score more than 2, you can have two extremes. One with a single episode of paroxysmal AFib, where we religiously go for anticoagulation as per the current recommendations. Another subgroup where you have not recorded any atrial fibrillation, but with very high AFib burden. In this case, we may actually miss some of these patients who may really require anticoagulation. I think the missing link in this complex equation could be the atrial substrate. When you have a large atria, atrial cardiopathy, atrial substrate modification, these cases are at very high risk for recurrent stroke, or maybe LV diastolic dysfunction and other markers, LAVI, like left atrial volume index. So probably addition of this factor into the chart score and looking to differentiate the patients at high risk would be really beneficial. This is my just personal opinion. We need more evidence on this.
Yeah,
If
the
we-
obvious difficulty there is that the mass application then gets restricted. So sure, I think this is endless and it's interesting though. Let's move on, Naran, I think. Yeah.
Yeah.
Okay.
The third talk is on Dr. Naini. Can you please share the presentation? It's on SBRT and recurrent scar VT. It's being presented by Dr. Naini Makar. She has completed her fellowship from Sri Chitra just a month ago, and it's wonderful, great knowledge and great application at clinical level. I look forward to her presentation. Dr. Naini, over to you.
Thank you, sir. So, the article I'm going to discuss today was recently published in JACC Clinical Electrophysiology, and it discusses the efficacy and safety of stereotactic radiotherapy in patients who have recurrent ventricular tachycardias. So since our talk is tailored to a DM audience, and it is almost considered blasphemous to begin a talk on SCAR VT without discussing Stevenson's original model, we need to understand how radiotherapy works. We first need to understand how SCAR VT originates. So particularly in patients with ischemic heart disease, we do have a scar, but the scar is not uniform throughout. So for instance, when we look at this endocardially made voltage map, so a voltage map would measure the voltage of all the potentials recorded in various endocardial regions. So, and everybody would color this differently, but in this case, like where this is represented, the red region represents regions which have voltage of less than 0.5, whereas the purple region represents normal myocardium where the voltage is more than 1.5. It is somewhere in between these two regions, which is the border zone, where there are connecting channels. Now, these channels, like Stevenson originally described, behave like zones where slow conduction can take place and make re-entry zones around the rest of the scar, perpetuating a tachyarrhythmia. Conventionally, we think of these to arise in ischemic heart disease, and ablation strategies and other strategies have been tailored to ischemic heart disease because this represents a large chunk of this population. But this is equally common in other non-ischemic substrates, including and particularly apical HCM, where the scar may surround the LV aneurysm, and ARVD, in which patients are known to have more epicardial and endocardial scar. So when we see all this, we realize that when we are trying to ablate these circuits, there are multiple problems. The first is that these scars are not homogeneous. We don't expect the dense scar to be fully densely scarred. So we assume that there are channels in the border zones, but there'll be multiple channels in the scar itself. And ablating the entirety of this region may not be feasible or practical. So we have to resort to some other strategies. But before we resort to other strategies, let us review the evidence we have for current strategies in SCAR VT. So the first therapy that was available beyond an ICD is, of course, and that is the first strategy most of us would default to when treating patients who are getting ICD shocks, is antiarrhythmic drugs. So what happens when we review the evidence we have for antiarrhythmic drugs? So quite honestly speaking, the drugs that we do have available for patients who have diseased hearts and are having VT are amiodarone, sotalol, and probably mexiletine in our country. Other drugs, including azimilide and dofetilide, are currently not very widely available for our use. So when we talk about amiodarone on top of previously implanted ICDs has been shown to reduce the risk of ICD therapies. That being said, the toxicities of long-term amiodarone use are so widely known, and in fact, there are studies which have shown an increase in overall mortality from amiodarone based on its side effect profile. So the routine use of amiodarone in all patients, especially at very high doses, say more than 300 milligrams per day, becomes restrictive. The other drug would be sotalol. So sotalol, again, in some studies has been shown to, like in this Pacifico study in particular, which is frequently quoted when we talk about sotalol and ischemic VT, it has been shown to reduce the risk of again ICD therapies in this subgroup. But the notable thing here is that when we add sotalol on top of pre-existing beta blocker, which all of these patients should be getting, then it does not confer the same benefit that we think it should. The other option we have is catheter ablation, and particularly what has been in vogue of late, that should we perform catheter ablation upfront at the time of an ICD implant in patients who have been resuscitated or who have had a prior VT, who are getting an ICD for secondary prevention or not. And I will only discuss these couple of trials to bring out as to what we are looking for as an endpoint in these patients and why. So when we look at the initial trials for ICD in secondary prevention, ICD already confers a 40% approximately risk reduction. So the hazard ratio with patients who have an ICD has been around 0.6 to 0.65, which means that an ICD has already significantly reduced the mortality in the group. The remaining patients are so morbid and have such a high mortality that to show a mortality benefit, we would really need a very large sample size. Barring that, it may not be possible to show a mortality benefit in this subgroup. So when we talk about prophylactic catheter ablation as well, there are two schools of thought. The first, this study published by Dr. Reddy's group, which chose the primary composite endpoint to be ICD therapies or mortality, showed that patients who undergo ablation perform significantly better than control. In contrast, if you take the primary endpoint only to be heart clinical endpoints, which would probably be death from any cause or heart failure or VT hospitalization, then catheter ablation patients fare the same as patients who undergo just ICD implants. So it is all in the perspective and really not much else. Again, so the previous two studies were in patients who have ischemic cardiomyopathy. If we consider a more heterogeneous subgroup, so this study, or the PAUSE SCD study, which was more recently published, had almost 2/3 patients who had non-ischemic substrate, almost 1/3 of which were ARVD. Even in this, when we perform prophylactic ablation, the number of ICD shocks reduces, but the overall heart clinical outcomes do not change. So of these two, once you have put an ICD and the patient is continuing to have recurrent therapies, what would you resort to, catheter ablation or drugs? Again, if you consider a composite outcome of ICD shocks plus mortality, then ablation probably tends to fare a little better. Although if you were to consider only death or hospitalization, then again the outcomes for all of these would be similar. So where is the problem? The problem is that in patients who undergo catheter ablation, over long-term follow-up, they continue to have very high mortality rates. So in this long-term follow-up study by Dr. Stevenson's group, they had almost 20% mortality rate over long-term follow-up, and nearly 1/3 of this is driven by recurrences of VT episodes. So even after catheter ablation, a significant proportion of these patients will continue to have VTs. Either this is a different morphology of VT, or it may be an epicardial substrate or some other VT that was not addressed in the previous ablation. So what are the options we have when catheter ablation is failing? These are some of the things that have been tried, and most of them for the present time remain investigational. But these have been tried in various substrates of patients. These include transcoronary ethanol ablation, bipolar radiofrequency ablation, intramural needle ablation, stereotactic radio ablation, and autonomic modulation. We are going to discuss stereotactic radio ablation in a little more detail in the subsequent slides before I discuss the study itself. So cardiologists are actually quite late to join the group of stereotactic ablation technology. This was actually intended for and is currently being used in many malignancies known as SBRT for the systemic malignancies and stereotactic radiosurgery in brain malignancies. This is particularly, so the major benefit it offers over other radiotherapeutic strategies is it is highly precise. To the level of 3 to 4 millimeters, it is precise, which means that particularly when you have tumors that are small but are inoperable because they are close to adjacent structures which are vital, then this becomes a good strategy. The second benefit is because it is giving radiation to a very localized small area, it can give very high doses of radiation. So conventionally for cardiac radiation, doses of 25 gray are used, but it is thought that the center of the radiation target area is receiving much higher doses, up to 40 grays of radiation. So again, the mechanism of this, and I will not go into this, is cell death mediated primarily by cellular hypoxia and vascular damage, in addition to the immune response to all of that. And that remains the case in the cardiac situation as well. So the hope was that stereotactic radiotherapy would sort of homogenize the scar, removing the intrascar channels and hence abolishing VT. But what were the problems that were specific to the heart that caused, some reluctance in initially accepting this? The first is that we need a very high positional accuracy. If we are radiating close to the left main and we end up irradiating the left main artery, then it can cause something that obviously we did not intend to cause. The second thing is the target volume. So if we were to target a larger volume than is necessary, would we end up causing ventricular dysfunction was one of the initial concerns. And of course, there's a surprise factor of cardiac motion. So when you're giving it to such a localized area, and precision is very important. Respiratory motion has been considered in lung tumors as well, but cardiac motion is another anomaly that we need to now adjust for. So how was this done? This is one of the initial studies. So basically, the first thing that we do is we decide what area of the heart needs ablation. This is defined by the scar region. And then, so to adjust for cardiac motion, a slightly larger margin than the scar area is given to the machine to be irradiated. Additionally, especially for more accurate respiratory gating, sometimes a fiducial marker may be used. I'll just come to this better in this. So this was one of the landmark studies published in NEJM in 2017. This discussed 5 patients who underwent cardiac radioablation for refractory ventricular arrhythmia storms. And as this study reported, there was almost 99.9% reduction in events following stereotactic radioablation. So how did these people perform it, and how are centers that are currently performing this? So the first thing is to delineate the scars, and most centers that are currently doing it will use a combination of electrocardiographic and anatomical techniques. So anatomical techniques would most often include either cardiac MRI or SPECT PET, which would delineate the region of scar. And this, in addition to this, there would be EP mapping. So a lot of centers even now, and this is not very available in India, and it is probably beyond the scope of my talk, are using non-invasive systems, mapping systems, such as ECGI, to create the map of the scar. So ECGI is basically like, so some of the endocardial maps we saw previously where the scar was demarcated, that is of course marked endocardially. But if you were to not want an endocardial procedure because it is invasive, then you could use some of these systems to mark the exit of the VT sites and the regions of scar. This is based on multiple chest electrodes, maybe to the tune of 256 in the case of ECGI, can be many more. So we use these two techniques, and these two are superimposed or correlated to identify the arrhythmogenic scar substrate. Now, this target volume is then calculated based on this, and the patient is immobilized in a special vacuum structure, which would allow the radiation beam. Both C-arm-based beams and roving beams are available. In the study we are discussing today, a roving beam has been used. Some of these, particularly the roving beam, would require an additional fiducial marker in the heart, which would basically account for cardiac motion. This, in this particular study, the ICD lead, which was present in all patients certainly, was used as the fiducial marker to mark for the cardiac motion. So what is the current scenario and what do we know? The first thing to say here is we don't know very much. This is the largest study that was published in Circulation in 2019 that was available before the trial for discussion today. This had 19 patients with recurrences and episodes of ventricular arrhythmias after catheter ablation, or those who had contraindications to catheter ablation. And all of these underwent SRS. And after 90 days to 6 months of follow-up, they tended to do reasonably well with the improvement in quality of life, a significant reduction in VT episodes, a fair survival. So they had around 70% survival, which in this population would be quite acceptable, and a reduction in doses of antiarrhythmic medications. But we did not have much data on long-term follow-up, and particularly safety data and long-term efficacy data were both missing in the population, which is why the current study was undertaken. So what is the design of the study? So the study population consisted of 2 cohorts. There was an efficacy cohort comprising 17 patients and a safety cohort comprising 36 patients. Basically, the intention for this is that the study was spread over a long time. So the study period was from 2014 to 2020, which meant that some of the techniques were still evolving at that time, and the safety cohort has some heterogeneous population, in some cases of which older techniques were used. But the efficacy cohort, which is all done in more recent times, had a more optimized, homogeneous kind of protocol. So all of the patients in the efficacy cohort had undergone 2 or more catheter ablation procedures at 2 of their designated centers, which were considered expert centers for VT ablation. And they used the most accurate technique for target volume determination. This was an invasive electroanatomical mapping, either a CARTO mapping in their case was used, and co-registration with a cardiac CT was done to map out the scar. And the ICD lead was used as a fiducial reference for a roving system to deliver the radiotherapy energy. In the efficacy cohort, patients were followed up for a mean of 14 months, and analysis was done per patient. In addition to 2 catheter ablations, at least 2 of which were done, 2 of these patients had undergone 1 prior stereotactic radiotherapy procedure as well. The outcomes in this cohort, in the efficacy cohort, was time to first ICD therapy, any repeat catheter ablation or repeat star requirement, all-cause death, and adverse events. The safety cohort, like I said, had less stringent inclusion criteria, and these patients had a median follow-up of 33.5 months. And per procedure analysis instead of per patient analysis was done. So in the case of 1 patient, he underwent 3 star procedures in this case. So let's look at the patient characteristics. So the standard characteristics are predominantly male, advanced stage, which is the characteristic of this population. What we should note here is, particularly in the efficacy cohort, and in contrast to data from what we had in the prior studies, only a third were ischemic cardiomyopathy. Almost 2/3 were non-ischemics. So that has probably skewed some of the results. Additionally, the inclusion criteria was 2 prior endocardial ablation. 10 of the 17 patients in this efficacy cohort had also undergone epicardial ablation. And like I said, 3 of them had also received SBRT prior to this inclusion in the criteria. All patients had a median procedural time of 58 minutes and volume was around 40 ml. These were the prior procedures that the patients had undergone. So 1 patient had undergone 4 endocardial and 1 epicardial ablation before inclusion into the study. So let's look at the efficacy outcomes. Broadly speaking, for the efficacy outcomes, these patients had a very high mortality. In fact, they had a higher than anticipated mortality as compared to the previous trials. Part of this discrepancy is arising from the fact that probably based on their profile and the number of prior procedures, these patients were much sicker than previous studies had chosen to include. So at 1 year, their mortality rate was 47%. Nearly a third had undergone redo procedures by the end of 1 year. And if we consider only the survivors, then almost half had undergone redo procedures. The other notable thing is that while other trials, including the circulation paper I just discussed, had considered a blanking period of around 6 weeks, this study did not consider any such blanking period. And it is considered by some scientists that the efficacy evaluation of radiotherapy should be considered after 6 months. So only 10 patients survived till that point so that it could be analyzed. There were 2 very early deaths. It is unclear if these were procedurally related, but they were due to worsening heart failure in both cases. So this is how these patients fared. If we consider only the efficacy subgroup, so this was 17 patients, 15 patients had VT recurrences, and almost the majority of them eventually underwent repeat catheter ablation procedures. Here is where things start to get a little more interesting. So if we consider the number of patients who received ICD therapies, all patients received ICD therapies in the efficacy subgroup. That means all patients received ATP, but only 80%, 70 to 80% received subsequent shocks. And I'll show the schema of the shocks as well. What this means is many more of the episodes that were previously being shocked are now terminating with ATP. And along with this termination with ATP, it was also noted that if VT had the same, they had 12 VTs, which had exactly the same morphology pre-procedurally and post-procedurally. So when they remapped these VTs, there was a significant slowing of the tachycardia cycle length from, I think, 330 milliseconds in pre-procedurally to 440 milliseconds. So definitely some modification of the scar had happened with this procedure. So if we look at the DC shock burden, and in the initial 6 weeks, it remained high. But like I said, this has been considered by some people to be a blanking period in which the effect is still taking place. Beyond that, the number of DC shocks actually reduces significantly. And the number of ATP terminated episodes remains almost constant to slightly actually reduces as well. This is depicted again here. In both paired and unpaired comparison, the number of DC shocks are significantly lesser, especially if we consider the efficacy evaluation beyond the 6-month mark. So more important than the efficacy in many cases is the safety, because if we are doing something, we should first cause no harm. So this was the major adverse effect. So some minor adverse effects, including nausea, esophagitis, etc., were noted in some patients, but that I will not be going into the depths of. The major problem was a progression of mitral regurgitation, and this was noted in 8 of these 17 efficacy patients. This included the mitral valve intervention in 3 of these patients. 2 patients underwent mitral valve surgery, 1 patient underwent TER. But the reason for this mitral valve progression of mitral regurgitation, so initially it was thought it could be related to the papillary muscle dysfunction, but there was no significant association with papillary muscle irradiation. However, if we consider the patients who underwent radiation to the basal inferior inferolateral wall, all the mitral regurgitation worsening happened when irradiation was given to these segments only. And in most cases, they have shown that it is because of an increased tethering of the posterior mitral leaflet that this mitral regurgitation worsened in these patients. The other major complication that has been noted previously with this technique and was noted again here was an esophageal pericardial fistula. This patient died because the fistula could not be closed. And they've also mentioned that this patient had undergone CABG prior using a gastroepiploic artery, so that may have predisposed him to developing this complication. So like I said, when radiation was given to the basal inferior and inferolateral segment based on AHA's classification, then the risk of mitral regurgitation and the requirement for mitral valve reintervention was much higher in these patients. One notable thing was at 6 months follow-up, when the LV function was reassessed, it was not significantly different from the LV function pre-procedurally at baseline. So what is the limitations that this study has? The first is that it's a very small sample size. And not only is there a high mortality, there is a higher mortality than we began to anticipate. There are some missing data points. I'll just come back to that point. The other thing is the lack of a control group. So had we had a control group that had not received STAR, we would have been much wiser as to whether the STAR was changing the prognosis of these patients or it was all by chance. The other thing is, since all patients had repeat catheter ablation, we are not sure if this is an effect of radiotherapy or an effect of catheter ablation itself. The safety cohort, like I discussed, was a heterogeneous population. The intervention was not homogeneous in this. Now, the most important thing is regarding the mortality. So they recorded 18 mortalities in the safety subgroup. Nearly 2/3, 12 of these patients died because of worsening heart failure. They have measured LVEF at 6 months and shown that it did not deteriorate compared to baseline. But that is not to say that there is a long-term decline in LV function. That could very well be possible. In several patients, there is missing device data between the last interrogation and patient death. This means that the patient could have had recurrence of VT that worsened LV function or VT storm that could have led to that outcome, and we may not know about that. So here are the takeaways that I would consider from this. So definitely there is some partial modification happening. There is a reduction in DC shocks and there is a slowing of VT rate. So the SCAR is being modified by this technique. Like I discussed earlier, to show mortality in such a heterogeneous and high-risk population is technically and statistically so difficult that it may never be done. So in that case, should we accept this reduction in DC shocks, particularly in such patients who have already undergone 2 catheter ablations and continue to do poorly? Maybe it would be a viable alternative to a 3rd catheter ablation. That being said, it is still in its nascent stages. It still has to grow and evolve a lot before we know what exactly we are doing and we can imbibe it into routine practice. And of course, in our country, it will continue to have some financial restrictions, and it needs a good radio oncologist or a radiotherapy suite to be able to give this to our patients. And the safety concerns are valid and serious. In patients who have pre-existing mitral valve pathology or esophageal disease, we may want to think 2 or 3 times before we go for this intervention. Thank you for your time. And as our teacher always tells us, our duty is only to do what we can best for the patient. The rest should be left to the Almighty.
Thank you, Dr. Naini. Wonderful presentation as always. Very lucid, clear, and comprehensive, and well summarized both the study message as well as the essence of medical practice by quoting Bhagavad Gita. So now we have an expert here. I should say he is an expert par excellence, Dr. Deepak Padmanabhan, who has tremendous experience in this field of SPRT in the country. And I look forward to his insightful comments. Deepak, over to you.
Thank you, sir. Thank you for that very, very kind introduction. At the outset, very well presented by Naini. I think she brought out the limitations very well as potential benefits that you might accrue. As with any existing technology, the solution already exists. We are essentially searching for a problem to solve with this particular technology right now. Coming and focusing essentially on the study itself, in my opinion, the study is a challenging study to interpret for me also, because of the very nature of the substrate that was being dealt with, non-ischemic cardiomyopathy, where we don't really get an essence from the study as to what the distribution of the scar was. How did they decide where they want to go ahead and deliver radiation? And what was the area of scar involved that was eventually targeted by this particular subset? Maybe the data was there and I did not pay attention. That's a possibility, but I didn't get a sense of that, number one. Number two, what it definitely tells us is there is modification of substrate. The posterobasal region leading to mitral regurgitation is something that we would expect. And appropriately so, we have the abnormal mitral valve function that has been documented in this group very well. The strengths are most definitely the long-term follow-up. The strength is the fact that we have been able to document that these patients have done badly, and it probably can be taken in two ways. One, perhaps an earlier intervention in a different subgroup of patients would be the choice to go. Or number two, we definitely needed more data between the last device interrogation and the last follow-up or information regarding these patients that we had. To this same effect regarding the potential ability of this therapy to modify substrate, I would recommend reading of a recent heart rhythm paper by my colleague, Dr. Kancharla, who had a animal model of a scar-related myocardial infarction, which then he had a survival animal study on and did electroanatomical maps on. It's a very elegant study talking about the scar, the histology, how much mattered, how much scar was caused by the MI, how much additional scar was caused by the SBRT therapy, and so on. So that provides us interesting insights into this particular therapy. Where I think the field might go is anyone's guess, but I do think there is a niche role for this therapy. The only thing perhaps that I would disagree with Naini in her presentation is the fact that it is the inverse. Cost is perhaps not the factor in this therapy as much as it would be with conventional techniques in our country. That would be my summary for this particular trial.
Any comments from other panelists?
No, so Narayan, we can easily sum it up by asking you as to, despite this not so bright results, why do you think this technology will work?
It's in fact, it is in the high-risk population and a bailout procedure. When you have two limited limited access to LV, failed ablation, and of course, patients with a double wall replacements. In certain cases where we have no other option, and otherwise very very comorbid problems where you cannot take these patients for any invasive procedure. This is semi-invasive, and this definitely helps in that subgroup. But the question here is with the high incidence of mitral regurgitation noted with the post-basal irradiation, and of course, with the posterior irradiation, you have atriopericardial fistula, esophagopericardial fistula. And of course, septum is not a epicardial structure, and there is limited role for SPRT in septal to great extent, largely. It's almost always limited as a safe procedure to anterior or apical segments. That is one concern I have. And I think Dr. Saxena is raising hand. Sir, please. Dr. Saxena?
It was a good presentation. I don't have much to add. I think everything has been covered, and I agree with your comments and Dr. Deepak's comments. So I think it's something to look forward to in future. I mean, we don't know how eventually it will evolve, and which patients, particularly as you mentioned, patients who are too sick to be taken for catheter ablation probably will be the first potential targets of this therapy. Maybe we can help them. But other than that, I think it has a long way to go, because eventually we are all looking at non-invasive solutions to help medical problems. And so let us see how it goes, how it progresses.
So we are obviously limited by time, but I will have Dr. Deepak making comments on the other two presentations which didn't moderate, and Aurus I am seeing is still around. So if he can talk on other presentations, whatever burning points he wanted to address. And I'll let Dr. Narayanan close this session. It was obviously wonderful, and I thank the Sri Chitra team for this. Sure. Deepak, you want to come in or
Sure.
Please.
Yeah, I just want to make one last comment on the last presentation. One substrate that was perhaps not discussed in all our comments was apical aneurysm with thrombi. To me, in our country, that is probably the role where I would be a little bit more aggressive with using SBRT rather than just conserving, and I would limit the radiation field to that region. That might be very valuable, because it's a substrate where only epicardial access for ablation might be possible given the thinness of the myocardium and the presence of the endothelialized thrombi. Playing around there may not be a good idea. And maybe this is one of your procedures that you can give for palliation, since VT ablation is by and large a palliative process for the majority of it, number one. Number two, I think the findings of the Arrhythmia trial were very, very well taken. And I think the discussion was fantastic, especially with regards to the underlying substrate and the potential of the underlying substrate to actually worsen or cause a stroke independent of the presence or absence of atrial fibrillation. And I think the guiding factor for all of it has to be the CHADS-2 score. And that should guide what you want to do, along with a burden of at least 5.5 hours, in my opinion. Anything less than that, I think we'll have to really judge why and where in terms of what we are doing. As far as the modular ATP with the subcutaneous ICD is concerned, I think, again, it has some ways to go. It probably allows the extension of the SICD into the subset that might require ATP pacing for termination of arrhythmias, because I think the SICD is brilliant if ventricular fibrillation is your target arrhythmia that you're trying to protect from. But if it is an ischemic substrate or an arrhythmia that is monomorphic, you would have ATP as one of your very powerful methods of intervention to avoid the arrhythmia per se. So it might be targeted towards that subpopulation, although what Dr. Saxena said with regards to the cost might actually be a eventual reality. Thank you for the opportunity to present. I think this was excellent in terms of the concept, and we should do more of this in the future. Thank you.
Thanks, Deepak.
I
Auras?
think,
Thank you.
yeah.
Just one final comment about the last study, actually, about STAR. The one thing is, this is data presented by Dr. Joseph Kortzner's center. And if you see the other major group coming out with the SBRT data, it's mostly led by the consortium led by Dr. Philip Kuklich at Washington University. One key difference is the approach. I think Dr. Kortzner's center is a VT ablation center, really par excellence. They have very high volume and they are very aggressive in how they ablate just by catheters. So the potential value of of a bailout in someone who has ablations that have really been performed to the best of their ability may show some differences in the results, I feel. I mean, I think if you use SBRT as an alternative to catheter ablation for simple substrate, it'll work. This is really their patients are really, really high risk where catheter ablation, no matter at what level you do it, is not working. So I think that's just something to keep in mind. I mean, we will never be able to compare it because as Dr. Makar said, this sort of population, you will not be able to compare every aspect.
Yeah. Thank you, Dr. Atreya and Dr. Padmanabh. Valid comments. In fact, any test should stand the test of time, and especially true for advanced therapies like this. But all these studies represented trials which looked into evolving therapies for a specific population, whether it is modular ATP or a SBRT. So there is something in common, and the message is very clear. You have to select the population clearly, and we have to apply in certain clinical subsets only. And with the evolution of time, this therapy will definitely improve in its clinical application level. With these words, I think we should summarize this session. I thank everyone, Dr. Nabbar, for involving Sri Chitra in the entire session, and my senior colleagues like Dr. Saxena, then Dr. Atreya, then Dr. Padmanabhan, and everyone, and for all my colleagues for presenting the journals, and all for participating in the entire last 2 hours. Sorry for exceeding the time, and thank you all.
Sure, no, we were always glad to exceed time because this is informal and educative. So we are very happy that Sri Chitra contributed once again. My special thanks to all the three moderators. They actually took out the time on a Sunday morning to do this for us. For ours, it is Saturday night. So thanks to all the moderators. We'll meet again next month, September 1st Sunday. Remains the same 10 o'clock. And Dr. Muralidharan's stream from Chennai will bring in something good for the postgraduates. Thank you very much and have a nice Sunday. Bye-bye.
Thank you.